our FY1 preparation series, which is our new series for 2025. This week we've got the MDU here, and thank you very much for joining us. And if you have any questions during the session, please pop them in the chat and we'll do our very best to address them. And at the end of the session, I will share a feedback form. And if you complete this, you will receive a certificate of attendance with some exclusive discount codes as well. I have also recorded this session, and the recordings will be shared on our learning portal. So make sure you make an account with our learning portal and check out all of the resources there. There is also an exclusive question bank on our learning portal as well. Just before we begin, we would like to thank our partners, Geeky Medics, More Than Skin Deep, Medal, Teach Me Surgery, and Pass the MRCS, and of course the MDU. And without further ado, I'll hand it over to Shay, who is from the MDU. That rhymed. There we go.
Fantastic. Thank you very much. So as mentioned, my name is Shay. I'm here from the MDU, and what I'm looking to do today is I'm just going to give you a quick overview of the sorts of things that we typically see here at the MDU, some of the common pitfalls and areas where doctors might see things go wrong or where they might accidentally land themselves in trouble, some ways that you can minimize the repercussions for doing so, and some top tips on how to keep yourself out of trouble. So I'm just going to load up my screen share and get my presentation on the go. Fantastic. So I'm assuming that you can all see that okay. A little thumbs up would be appreciated. Fantastic. So this is a little snippet from our GMC and Keeping Yourself Safe seminar. Like I say, we're going to be looking at the sorts of things that might come up, or you might see in a GMC investigation, and how to keep yourself safe from a medical legal perspective. So first off, this is usually the point in the presentation where I'd say to people, put your hands up if you think that the GMC is there for doctor safety, or there as a patient safety body. But of course, we don't really have the facilities for doing that since we're virtual. So I'll give you a quick spoiler. Generally speaking, the role of the GMC is public protection, so keeping patients safe. More specifically, you'll see on the screen here, these are the GMC's various roles, which are stated on their website. So they're involved in setting standards, which will include things like publishing guidance, like your good medical practice. You'll get ethical principles as well, like consent or confidentiality. And there's also specific guidance on tricky areas, like safeguarding, child protection responsibilities, providing care for people who are going through death. So they also oversee education and training. So this is going to apply to both undergraduate and postgraduate. On top of that, there's around 363,000 doctors on the UK Medical Register, or at least there were when we took this statistic in 2023. But the GMC do need to check the background and qualifications for every single doctor before they can join that register, and they'll also manage the register by assessing a doctor's fitness to practice, and they'll do this by asking the medical school and possibly previously employers as well, about their history and concerns. So the GMC's view is that over time, revalidation should help to improve standards of care overall. And this is done by identifying problems early on, and helping doctors to reflect in their practice to improve it over time. Just as a quick note as well, you'll see a QR code in the bottom corner of the screen for most of the slides that I've got in this presentation. That'll just take you straight to the MDU application, where you can get your own MDU indemnity in place. So please feel free to give that a scan, and get yourself a quote. So, as mentioned, the GMC do see themselves as a patient safety body. So every year, around 2 to 3% of doctors are referred to the GMC. Now, I know this number might sound a little bit alarming in the meantime, but only a small percentage of those are actually investigated. And when they're not, there's a high chance that a doctor might not even be told that the concern was raised in the first place. So generally speaking, a fitness to practice investigation by the GMC would be one of the most stressful times within a doctor's career, but the vast majority don't end up receiving a sanction or a warning. So statistics do run 18 months behind, hence why we have slightly older figures here. Although the number of doctors that you'll see on the register has gone up over the years. And even then, the number of inquiries has remained relatively static, around 8,000, 9,000, and a total of 10 in 2023. But if you look at the great number of doctors on the register there, it's really not that much of a significant increase. Again, even though these numbers do seem quite large, only a small portion of these are picked up by the GMC because a lot of them don't reach that actual threshold for concern for a full investigation. So, where might you actually get complaints to the GMC from? Well, where that complaint comes from also has an impact on how seriously or how far the investigation will be taken by the GMC. A lot of complaints are made by the public, but employers can also refer some of their doctors to the GMC. Doctors can also refer other doctors, or self-refer to the GMC. You can have information from the police as well. Of course, they're going to be telling the GMC of any criminal matters, and the GMC themselves can pick up concerns by looking at things like media reports. You'll see others in public capacity at the bottom of the screen here as well, and this just refers to things like the coroner's office or other regulators. So I mentioned earlier that employers are a source of complaints to the GMC. The GMC does have a countrywide network of employer liaison advisors, or ELAs. I'll be saying ELAs because that's a lot less of a mouthful for the sake of this presentation. But they'll cover each region of the UK. So some of the ELAs will be doctors. Others have a variety of backgrounds like solicitors or medical professionals, all of which have been through an appointment process to take on this role, so they are qualified for it. The ELAs are also going to have links with medical directors and responsible officers, so that's how they'll get advice on revalidation and any doctors holding fitness to practice concerns at the moment. So the GMC will typically investigate anything that, if proven, might indicate an impairment on that doctor's fitness to practice. So most complaints are made by the public, and these are going to be things like clinical competence or professional performance, often combined with allegations about communication or overall respect. Complaints from employers are most likely going to be things about, I don't know, professional performance, or even a doctor's health. If they, for example, think that there's going to be an underlying alcohol dependency, obviously that's going to need to get looked into. Unsurprisingly, complaints from the police are always going to be about criminal matters, and these are going to be taken very, very seriously by the GMC. Even if you're found innocent in court for a criminal issue, and as far as you're concerned, it's been resolved, the GMC can still further investigate that same issue if they should choose to. So this slide here isn't a particularly cheery one, and I'm not using it to scare you. But although it is uncommon to face a fitness to practice hearing, the stresses in a doctor can be incredibly overwhelming at the time. But at the end, at the MDU, this is our bread and butter. It's what we do every day. So if any of you are unlucky enough to be subject of a complaint to the GMC, it's certainly not something that we would expect you to go through alone. So please do let us or your other defence organisation know straight away. If you are an MDU member, our advisors and legal teams offer advice and support right from the very start of the interaction. And early advice and a good response can prevent things from getting much worse further down the line. We also have a peer support network. So this is made up of members who have already been through a GMC investigation, and they will share their own experiences of coping with the process on there as well. So you're definitely not alone in these sorts of situations. And although these are very stressful to go through, they're still relatively unusual to get. And even then, only a very small portion of doctors actually end up with any restrictions on their practice. So although roughly 2.5% of registered doctors were referred to the GMC in 2022, 83% of those cases were closed, and most of which were at a very early stage, so there wasn't much of a process to go through, meaning only 273 doctors that year were actually referred to hearings. Once you're in a hearing, it's quite likely that you're going to walk away with some kind of sanction, but the point of this talk is to give you some information to help your peace of mind if you do ever receive that GMC complaint, and hopefully it'll help to improve your outcome as well. So this is just a fictional scenario, but it is very much based on the sorts of things that we see at the MDU, hence why it's quite generic. So we'll have a quick look through this and we'll have a conversation about it then. So you've got Dr. A here, Dr. A was a foundation trainee involved in the care of Mrs. X. Very creative names, I know. Mrs. X has been treated on the medical ward for uncontrolled diabetes and made a good recovery on a new insulin regimen. So the consultant made a decision on a ward round that Mrs. X will be discharged home the following day if she remains stable. So Dr. A went to see Mrs. X the next morning. Her blood sugars were stable, so Dr. A did the discharge paperwork. Mrs. X then went home, but she was readmitted with leg pains less than a day after discharge. So before we dive into that, we're just going to quickly touch on multiple jeopardy. Some of you might already heard of this, but for a lot of people, it's a new term. So this slide essentially demonstrates the multiple jeopardy that's faced by doctors. So in other words, you can have one clinical incident and it leads to a lot of different investigations and outcomes from multiple bodies for that doctor. So in this example, Mrs. X's family wrote a letter of complaint to the hospital. They also wrote to the GMC and the local newspaper. Now, of course, everyone wants to get their 15 minutes of fame these days, but if you do look into some of the horror stories that you see about doctors in the papers, you'll find that a lot of the outcomes are actually a lot less clear than they made out to be. But just looking at this slide here, Dr. A would be looking at a disciplinary investigation, an NHS complaints procedure, a GMC investigation, and of course, unwanted media attention. Luckily, Dr. A was a member of the MDU, who could assist with all these issues at the time. So the family of Mrs. X referred Dr. A to the GMC, of course, and the allegations were that on the morning of discharge, she took absolutely no notice of Mrs. X's complaint of leg pain, and Dr. A came across as quite hurried and dismissive, wasn't really paying too much attention. So Dr. A received a letter from the GMC seeking her comments. Dr. A was obviously quite anxious and upset about this. She was struggling to sleep, and that's when she decided to call the MDU. So one of our advisors gave Dr. A information on how the GMC fitness to practice process works, and then we asked her to send over the GMC correspondence that she got in the first place. So our advisor looked through this and she saw it in quite detail. So she provided thorough advice and support throughout. Now, this slide just demonstrates that the GMC investigation would be the next part of that process. So at any time in this journey, a case can also be referred to an interim orders tribunal. I will come back to this again later in the presentation, but essentially they do this where the allegations against the doctor are so serious that if proven, it would mean that the doctor poses a threat to either the patients or the public in general. If you take something like sexual assault, for example, the GMC are obviously going to act on that almost instantly because, of course, they can't risk bringing any other patients to harm. So the registrar at the GMC is going to decide whether or not they should investigate. So the first thing to keep in mind is that the GMC aren't going to investigate just a single event. They're looking to see whether a doctor is fit to practice as a whole. So for example, if a doctor is being investigated for a complaint and then they find out that the doctor has a health problem, that's going to be considered when they determine the doctor's fitness to practice. The same goes if other complaints are picked up or found when they're looking into the original incident. These would be looked at in great detail too. So the GMC registrar must first judge whether the complaint would impair a fitness to practice if proven. If so, the GMC are going to decide to investigate. But if the allegation doesn't reach their threshold, then the registrar will close the case straight away, and the complaint is sent to the doctor's responsible officer. So in those cases, the GMC will write to the doctor, just requesting a copy of the complaint and advise them to discuss with their appraiser. That's usually best case scenario right there. So there's that on the timeline. Sometimes the GMC also feel like they need to get a little bit more information just to help them decide whether a case can be closed at that early stage or not. So in that case, they'll open up a more limited type of provisional inquiry and they'll also let the doctor know that they're doing so. So decisions are going to be made by collecting the medical records or any information that's currently existing about that local investigation. Alternatively, they can also ask an expert to review the information and comment if they have any further concerns. But the good news is generally 83% of the cases in 2022 were closed at this provisional inquiry stage, and it usually only took about a few weeks, so not too long for the doctor to be going through the stress. That being said, please do let us know if you get a letter about a provisional inquiry because there is sometimes value in commenting on them early, but it's definitely something to get advice on. When a complaint is to be investigated at GMC level, whether it's either a provisional investigation or a full one, the GMC will write to the doctor. They'll ask the employer's details and offer the doctor an opportunity to comment at this point, but there is no obligation to do so. Again, you would ideally speak to your defense organization at this point. But going back to our scenario, this is the sort of letter that Dr. A would have received about Mrs. X. It can be difficult to decide whether responding at this point is a good idea, which is why, of course, we would recommend taking advice. A lot of things to consider here as well. So any response that you make is going to go back to the complainant and it's going to become a part of the formal process as well. Also, if a letter of complaint is long and detailed, it can be quite hard to tell which aspects that the GMC are trying to pick up on. But despite this, it is sometimes a good idea to give an early response. So, for instance, if something did go wrong in the care and the doctor wants to acknowledge that, or if the facts of the case were maybe misstated, or if the doctor was just following specific local guidelines at the time, the GMC aren't going to look at what took place when something goes wrong, but more how the doctor actually dealt with that problem. So you're not expected to get right every time. Of course, we're all human, but you do need to be open and honest when something does go wrong and apologize where appropriate. That's going to be a great way of getting the GMC off your back. So the GMC are then going to consider if the doctor has shown insight, identified any shortcomings, or done something to put them right. Offering a response that includes these sort of details can often be key to settling a complaint at an early stage. But as I have already mentioned, these decisions about responding are really finely balanced, and we would strongly encourage doctors taking advice before doing so. So of course, if we go back to our little timeline diagram, this is where the GMC are going to begin to investigate the doctor. Now, when the GMC do decide to investigate, they're going to appoint a specific team to undertake that. They'll notify the doctor's employers at this point, and they'll also ask them for any further details of the complaint or any concerns that they might have surrounding them, so that the current complaint can be looked at in a lot more context. The investigation team will then take similar action to the provisional inquiry stage that we just looked at, but of course they're going to look into that doctor's practice in a lot more detail now. If the GMC believes that a complaint is an indicator of performance, they might ask that doctor to do a performance assessment. Similarly, they can also ask the doctor to do health assessments. So, for example, if there's a drink driving conviction, they're obviously going to want to know whether that doctor has an underlying alcohol dependency. But again, the doctor does have a choice whether to respond to allegations or not at this point. Now, at the end of the investigation process, all the information is going to be passed to the case examiners, and they'll make the decision on what happens next, as you can see on this slide. So, at the end of their investigation, the case examiners are going to send a letter, and their final decision and reason for it is going to be on that letter. So, similar to the ELAs that we already discussed, case examiners are GMC employees. Some of them are doctors, others are non-medical, but they will have the relevant experience and qualifications to hold up their post. And for every case, there's going to be two case examiners. One's going to be a medic and one's going to be a lay examiner per case. If the case examiners consider anything other than just closing the case, then the doctor will get another opportunity to respond here. The GMC will have set out clear allegations at this point, so the doctor can work on a detailed response with their defence organisation in the meantime, and generally the response wouldn't really be submitted at any earlier stage than this. The case examiners will take into account the findings of the investigation and whatever the response the doctor has made up to this point, also if they've shown any insight to correct their wrongs. So there's four possible outcomes that you'll see, and they're shown on the slide here. Sorry, three possible outcomes. So they can conclude the case, and that'll be with no further action, or possibly just a letter of advice, which is obviously the best case scenario here. Alternatively, they could refer the case to a fitness to practice tribunal, which is clearly the worst. It would mean a lot more stress for the doctor and more investigation processes, which is quite uncomfortable. And then the other two possible outcomes here are either undertakings or warnings, but I'll come back to these later. So thinking of the case of Dr. A here, Dr. A thought carefully about the case, but she didn't remember being told that Mrs. X had any leg pain on the morning of discharge. So Dr. A did remember that it was a particularly busy morning, so might have been in a hurry and come across as impatient to Mrs. X, which was actually included in Mrs. X's complaint letter. Dr. A checked the records and found that she had been made aware of a history of leg pain. It must have slipped her mind at the time because it was a busy morning. So Dr. A reflected with her training supervisor on the importance of making sure that patients are well enough for discharge, even if someone else has put that discharge plan in place. So just to conclude that case there, the MDU advisor helped her write a response to the GMC, including an account of what happened and a reflection. So Dr. A was able to include glowing letters of support from her training supervisor and other consultant. And then the GMC notified the advisor that the case was closed and a letter had been sent to Dr. A. So she was, of course, delighted at that outcome. But this case just goes to show how a reflective and insightful approach to complaints can be really, really important to minimize the outcomes. That's really what the GMC are looking for, is they do believe in remediation and improvement over time. So if you have that sort of insightful approach, they're going to look at you in a much better light. So the GMC aren't just looking at what actually happened in a case, but for evidence that a doctor has reflected, shown insight, and approved any deficiencies that are in their practice. So a reflective case discussion with a trainer is usually a really good approach. But again, speak to your defense organization. They're always going to keep you in the right. So Dr. A's case was closed, so she got that nice outcome right at the top there. This just illustrates the other possible outcomes that case examiners can make. And we're going to start off looking at warnings here. So the GMC use warnings as a way to mark behavior or performance that's fallen below acceptable standards. But at that point, it's not considered serious enough to go through the entire fitness to practice investigation or go further to a tribunal. So a doctor can decide whether to either accept this warning or request a hearing by the investigation committee. The investigation committee can then either decide to conclude the case, confirm the warning, or refer to a fitness to practice tribunal, which of course would be a worst case scenario. If they do accept the warning, that middle option there, then warnings will stay on the doctor's record publicly for 2 years, and they're always going to be disclosable to the employers as well. Undertakings are just a step more serious than warnings. So this will happen when practice limitation is deemed necessary, either because there's a problem with the doctor or because of health. So undertakings might include something like having to work under particular supervision or having to undergo retraining for a specific period. Doctors are going to be notified when this happens, and the undertakings are going to be put on the GMC website, of course, unless it's a health undertaking, which is going to be made private, but this is going to remain even after the undertaking is removed. So the case examiners are going to review this at interviews as well, and assuming that there's no further issues, it's likely that the doctor will be able to get back to practice. That being said, these undertakings can take place over several years depending on how serious the case is. So we've got another case scenario for you here. Moving on to a rather different kind of case from the previous one. So you've got Dr. B here. Dr. B was an F2 doctor who was working in the emergency department. So he saw a female patient, Mrs. Y, and Mrs. Y had made the allegation that Dr. B touched her breast inappropriately during the examination. So she didn't go to the police about it, but she did write to the GMC. So, of course, the GMC wrote to Dr. B to tell him about the complaint, and this was serious enough to trigger an interim orders tribunal hearing. So that was going to be happening the following week. So sometimes the doctor might not have done anything wrong in this case necessarily. You can have doctors that don't think they've done anything wrong and still receive this type of complaint. All it takes is a potential misunderstanding of something like looking into a chest pain or listening to a patient's heart for the patient to think that there has been something inappropriate taking place. Any sort of sexual or criminal issue will trigger a similar response with reference to the IOT. And this is just because the GMC are looking at the facts here. They're going to be looking at a serious allegation and whether or not it's likely to have happened. So of course they're going to trigger that IOT. So going back to this graphic here, at any point the GMC can refer the doctor to an IOT, and that's going to take place at the Medical Practitioners Tribunal Service. When they do this, it just means that the complaint is so serious that if proven, the doctor would be seen as a threat to either the patients or the general public. So IOTs aren't going to be a definite part of the GMC process. But the complaint that we just mentioned, anything sort of sexual or criminal, would likely trigger an IOT. So the purpose of an IOT is just to protect that patient. and it's going to be put in place whenever there's a potentially serious risk to other patients as well. So they're not going to look at the allegations in great detail. They just want to ensure that there's no risk to the public with this particular doctor and whether or not they should restrict that doctor's practice while the investigation takes place. But this is all going to get decided by the IOT, not the GMC's ELAs. So back to Dr. B then. He was obviously quite shocked, and he denied the allegations absolutely. He remembered the examination, but not that anything inappropriate had taken place. So he did call the MDU, and we instructed him with his solicitor because we could see that it's very likely this sort of thing would get taken forward. So the advisor and the solicitor met with Dr. B and they explained the GMC process, and our legal team supported him during the IOT hearing. The outcome was just that Dr. B isn't allowed to see female patients anymore without a chaperone. The health board agreed to this, and Dr. B carried on working in the emergency department. So the investigation continued, and the GMC took statements from the patient and other people who worked in the department that evening. So the MDU solicitor wrote to the GMC on Dr. B's behalf. They set out his account of events, and they reflected on the importance of making sure that patients actually understand what examination is being done. He apologized to the patient because they might have been unaware that he would need to lift her breast, and he explained why this would have been necessary at the time. So the statement of the patient was obviously consistent with the statement that Dr. B provided, and the GMC confirmed that Dr. B was in fact acting within reason, and it also held that his colleagues gave him positive testimonials. So the case was closed, with just a letter of advice about chaperones and providing explanations to patients, and the IOT was lifted as well, so we could see patients again without the chaperone. So overall, it was a good outcome, but it just shows the importance of communication during any sort of consultation where inadvertent touching could arise. So back to the list of possible decisions that case examiners can make. The one that I've not spoken about yet is the decision to refer a case to a fitness to practice tribunal hearing, which does take place under the Medical Practitioners Tribunal Service. So the intention of this is just to make the legal process as separate as possible from the investigation process. The Medical Practitioners Tribunal Service operates separately from the rest of the GMC. It's essentially just a courtroom in Manchester. So if you are interested, or even if you're in the local area, you can take a day trip and see it take place for yourself. So the tribunal just follows a three-stage process, and it's going to look at things like conduct, health, convictions, maybe decisions that have been made by other regulators. But the first stage is just to hear the evidence and find if the facts are proven. They'll then consider if this is going to impair the doctor's fitness to practice as a whole. And at that point, they're going to consider the insight that's been shown by the doctor, any remediation that they might have done, and testimonials from people around them. So finally, if the fitness to practice is found to be impaired, the tribunal will determine the appropriate sanction. If not, they'll close the case, but they can still issue a warning. So looking at possible outcomes here, you've got conditions. So these are similar to undertakings, which we already discussed, but unlike undertakings which are agreed, conditions are simply imposed. So this can include things like having to work under particular supervision, but the doctor doesn't get the opportunity to agree to this or not. It's simply, this is what needs to happen. You've got suspension, so this is going to be for a specified length of time, usually a number of months. And then you've got erasure here, which is essentially just the correct term for striking off. So it's clearly the worst outcome of the lot here. An erased doctor can re-register after 5 years, but it's a difficult process to get through. And for most doctors, erasure will be the end of their medical career. It's not very typical to find this outcome. It's for something as severe as, child abuse would likely trigger this sort of outcome. So a lot of you won't need to worry about that. So this is quite important here. It's an old study from the GMC, and what it does show is that even if you do get referred, you can do something to prevent the worst outcomes. So this could be something like a strong reflection, like we saw in both examples just there. You can show learning from what's happened, and you can apologize. So apologies are extremely important when something goes wrong. And this slide here just shows the difference between demonstrating insight and not. So where insight was shown, only 5% of the doctors in tribunal were erased. And where insight wasn't shown, 59% were raised. So quite a big difference. So this like goes to show that there were 814 full rather than provisional investigations that opened up in 2023. In the same year, 210 were referred to that tribunal. So a question that a lot of people ask the MDU is how many doctors are actually struck off in a year? Well, in 2023, we actually have data for this. In that year, 60 doctors were erased from the register. So this just goes to show that the numbers who are erased or suspended from the register are absolutely minimal as a proportion of all UK doctors. If you think there's around 378,000 that are currently registered, that number is minuscule. It's not even 1%. So that was pretty much that for the GMC investigation and tribunal process. So what we're going to look at now is some of our quick tips on how to stay out of trouble and some of the more common pitfalls that we've seen doctors fall into. So it's really easy during a consultation for you guys to maintain your professional boundaries. But outside a hospital or general practice, doctors meet situations where the boundaries aren't quite as clear cut and can become quite blurry. So what I'm aiming to do here is just highlight some of those situations where, in the MDU's experience, there have been a little bit more difficulties. A lot of them are from approved practice settings. So this will be all designated bodies. They're recognised as approved practice settings. So this means any UK organisation that has established clinical governance processes. This will include appraisal systems that support doctors with the revalidation and promote to protect the interests of patients. So all UK and international, medical graduates granted full registration need to work in an approved practice setting until their first revalidation, unless, of course, they also join the GP or specialist register at the very same time. So I've got a couple of prescribing scenarios for you here. The first one that we've got is an FY1. They wrote a private prescription for her father, who was saying he was staying with her for a week and he'd forgotten to bring his own antihypertensive medication with him. And then you've also got an F2. They wrote a private prescription for his asthma inhalers, and he had a 7-day quantity of Zopiclone. And this was because he was about to go on a long haul flight and he didn't want to have to consult his own GP. So in both of these cases, the pharmacist quite rightly refused to issue the prescription, and they told the doctor that she would be sending the prescription over to the GMC. Quite well justified, in my opinion. So this is what the GMC would say about these situations straight from the source. So wherever possible, you must avoid prescribing for yourself or anyone you have a close personal relationship with. Now that's quite vague and loose for the GMC guidance. There's a little bit of wiggle room in there for scenarios like being the only GP in a small town, where obviously you're going to know most people. So I suppose the takeaway from that is just don't do friends and family because it's surely quicker. You must not prescribe controlled drugs for yourself or someone close to you unless no other person with the legal right to prescribe is available to assess and prescribe without a delay, or emergency treatment is immediately necessary to avoid serious deterioration in health or serious harm. So we see a lot of these cases where doctors might get GMC referrals for either prescribing to themselves or close family members. It happens a lot more than you would think. So the GMC will investigate these, and a lot of minor cases are closed with advice. There have been others that are more serious and they've resulted in a warning or being referred to a fitness to practice panel. So definitely something that's very avoidable that you don't want to land yourself in. Further to that, the GMC say if you prescribe any medicine for yourself or someone close to you, you need to make a clear record at the time or as soon as possible afterwards. This should also include your relationship to the patient where relevant, and the reason that it was necessary for you to prescribe. So we've got another scenario here as well. There's an F2. He was invited by his rugby club to be the medical officer at a children's tournament. So he was a keen rugby player himself, and he thought that he'd be a good fit for the role because he knows the types of injuries that will occur during a match. So the first thing that you'll want to think of here for this F2 is expertise. Is there going to be any supervision or support available to him? Is it going to be an approved practice setting? Obviously, it's going to be on a rugby pitch, which isn't an approved practice setting. So it's quite unlikely that he'd be able to get approved indemnity for it. But the F2 contacted the MDU to ask for advice on this one anyway. It's definitely a case where you'd want to liaise with your defense organization if any of yourselves are thinking of doing something similar in future. But the advisor explained that the doctors can only take work if it is safely within their experience and competence. On top of that, the GMC also says that your educational supervisor needs to be aware of any plans to work outside of your formal training, and you need to follow any restrictions from your training body. So it would be unlikely that this is appropriate for an F2 to take on. It could be something for him to consider later on in his career. And even then, please do be aware that you would need to make sure that you have the right indemnity in place in case something does go wrong. You need to be able to protect yourself. So the GMC also states that doctors are obliged to help in emergency situations. So luckily, all MDU members receive professional indemnity for Good Samaritan Acts worldwide. So if an emergency situation does come up, you don't need to worry about approved practice settings. But it does need to be a genuine Good Samaritan Act and not something that you've foreseen. So you don't need to worry about getting sued in these cases. It's very, very unlikely that you'll ever pick up a complaint for a genuine Good Samaritan Act, but do still remember to act within the restraints of your competence. So this one's about a relationship. So this doctor saw a young patient with a wrist injury. She came in for a consultation and he found her manner to be quite flirtatious. And after she left A&E, he decided that it was a good idea to take her mobile number from her personal records. And then he sent her several texts asking her out on a date and stating how pretty he found her. So this patient told her dad, who quite rightly made a formal complaint to both the health board and then to the GMC. Another relationships one here, you've got another F2. He clearly had his priorities in place because he was about to do a 6-month placement in a rural GP practice, and he knew that the practice was the sole surgery for a large area. So what he wanted to find out was whether he was able to ask someone out if they were registered with the practice. So clearly he's got his priorities in place here. The GMC actually produced specific guidance on maintaining professional boundaries for doctors and patients in 2024. So what they say is you must not pursue a sexual or improper or emotional relationship with a current patient. Pretty straightforward. And on top of this, you must not use your professional relationship with a patient to pursue a relationship with someone close to them. So for example, you can't use home visits as an excuse to pursue a relationship with a member of that patient's family. Pretty straightforward. I'm hoping that most people that are listening to this would know both of those already, but if not, there's your learning for the day. So the consequences for the first doctor were quite serious, as you would imagine. So the trust investigation looked at both the attempt to start a relationship with a patient, but also the use of medical records for a non-clinical purpose, because he did take her number straight from there. So the GMC were concerned that the doctor didn't understand that his actions had been inappropriate. But after they read the doctor's reflections and looked at his remediation, the GMC were satisfied that it was unlikely to happen again. So the case was closed with just a warning on his record for 2 years. Obviously, he had a great defence organisation behind him for that. Looking at the second one, we would first need to consider whether starting a relationship with a patient is not appropriate or not. So the first thing you'd need to look at is whether that patient is vulnerable. So when we describe a patient as vulnerable, I think we would all agree that patients with sort of mental health problems or currently facing addiction would be seen as vulnerable, but also patients that have recently been through a lot of emotional stress. So this can be something like, I don't know, a harsh diagnosis, maybe they've lost a close family member, but these could also be judged as being in a temporarily vulnerable state. So thinking of that scenario where he's the only rural GP around, I suppose if you see a patient in a pub, an appropriate setting, and it's appropriate to speak to them and start a relationship, then by all means, that F2 can shoot his shot, he can crack on, then he can do so. But of course, that patient that he knows is at the surgery and that he's just started a relationship with, they can go to the same surgery, but they would need to see a different GP thereafter, because that would be a close, intimate relationship. So looking at chaperones, the types of situation where you would need a chaperone. Obviously, it's going to be intimate examinations, but then you need to think of what you would class as an intimate exam. So there could be times where, I don't know, a patient's in a darkened room. Maybe the doctor needs to get very close to that patient's face. Maybe he's constantly resting his hand on the back of the patient's chair. You'll also need to be aware of other situations where inadvertent touching could take place. So, for example, if you're examining a baby on a mother's knee, the GMC will have specific guidance on chaperones, but also your local health board is going to have its own policy. So just make sure you're aware of where that is and make sure that you comply with it. But if a chaperone isn't available, but an exam is very urgent, maybe if it's an emergency, make sure you just record your reasoning for going ahead in the notes, and make sure that the consent is also noted there. So I've already gone through this one lately. So just to summarize, in our experience at the MDU, the majority of cases regarding intimate examinations, they come from a failure in communication. So just make sure that if you're ever doing one, speak to the patient in a way which keeps them informed of what you're doing and why you're doing it. And make sure you consider your words carefully. So the best advice I can give you on this one is avoid using the words of a medical student that we've had. He was doing a thorough cardiology examination and he told that female patient that he was feeling for a thrill. Definitely not the best time to crack a joke, so be aware of that one. So here's some of our summarized top tips as well. Obviously, sometimes we don't know what we don't know. So just stick to working within your competence. And if you are unsure of anything, make sure you access that support network. Ask your colleagues. It's what they're there for. Good notes can obviously be the difference between a fitness to practice investigation and not. Make sure you keep good notes. That's always going to be your backup version of events. And it's always useful to go back and read records as well. So if anyone has any issues with you, make sure you try and nip it in the bud, deal with it early and to the best of your ability, otherwise it can get worse. And if something does go wrong, make sure you reflect on it pretty hard. So discuss what's happened, read about similar situations, read about the guidance, learn what you can possibly do to put it right, make sure you apologize. Do not wait for the appraisal and the investigation to take place before you start to think, maybe I was in the wrong. Make sure that you cooperate with the investigations. Don't fight them and deny them the entire time. Cooperate with that complaints procedure as best you can. And if there's anything that you're going to take away from today's session, it's that you need to take advice. If you ever get a letter from the GMC, call the MDU straight away. It's what we're here for. It's what you pay your membership for. It's so, so important to make sure that that's dealt with properly. So I'll allow you the opportunity to ask any questions. You can either shout out or simply put them in the chat box, but that's all from me today. So thank you very much for listening and for your patience.
Thank you so much for such a comprehensive talk on everything that the MDU does. I recently had an MDU talk at my university and we did not go into that much detail. So thank you so much. And you covered my question in the talk. If anyone else has any questions, please pop them in the chat now. We have a very knowledgeable speaker. I will see if... Okay. I've also put in the chat the feedback form. So if you fill in the feedback form, you get a certificate with our discount codes in. And once again, thank you so much for joining us tonight. We've got some sessions running next week as well on, I can tell you what they are as well. We've got 2 sessions running next week. We've got prioritizing tasks and common on-call dilemmas. And then we also have the surviving the first on-call shift. So 2 talks next week on the 18th and the 19th of June. Just a final massive thank you to you, Shay, and also thank you so much for letting us to record this meeting. We'll pop it on our learning portal so lots of people can watch it in retrospect. So thank you so much as well for giving us.
Thank you so much for having me. It's been a pleasure.
Thank you so much.
Thank you.
Bye-bye.
Bye now. Bye.